Anal melanoma. So it represents 1 to 4% of all anorectal malignancies. Third most common site for melanoma after the skin and retina. So skin and retina, and after that anal melanoma, accounting for less than 1% of all melanomas. So melanomas occur on skin and retina, then anal canal. It is most commonly seen in females, and the mean age of presentation is 60 years. Arise from the transitional epithelium of the anal canal, the anoderm, or the mucocutaneous junction. So anal melanoma, 1 to 4% of anorectal malignancies. Then third most common site of melanoma. So first is skin, second is retina, and third is anal canal. Third most common site of melanoma, and most commonly seen in females. Most commonly seen in females. And mean age at presentation. Mean age at presentation is 60 years. And arises from transitional epithelium of anal canal. Transitional epithelium of anal canal, that is the anoderm. Symptoms. The most common symptom of anal melanoma is bleeding PR. Let's go to symptoms. Most common symptom is bleeding PR. Bleeding per rectum, most common symptom. However, as in the setting of any other anal lesion, patient may present with pain, change in bowel habits, or tenesmus. Early lesions may be mistaken as thrombosed hemorrhoids. So you may mistake it as a thrombosed hemorrhoids. So other symptoms are pain, change in bowel habits, pain. So this change in bowel habits is important in diagnosing anal cancer, at least clinically. We must ask it in the history taking. Physical examination. A thorough physical exam, including assessment of the groin, should be done. And anal melanoma may be pigmented and either polypoid or ulcerated. Anal melanoma may be pigmented and either polypoid or ulcerated with raised edges. Satellite lesions may also be present. So on examination, anal melanoma is pigmented. It will be pigmented, either polypoid or ulcerated. Polypoid or ulcerated. And there will be raised edges and satellite lesions may be present. Histopathological diagnosis. The features resemble those of cutaneous melanomas. The features are of cutaneous melanomas. Majority shows a junctional component adjacent to the invasive tumor, which proves that the lesion is primary in nature. Majority shows a junctional component adjacent to the invasive tumor. Tumor cells express S100, HMB45, and Melan A. Perineural invasion is an important prognostic factor. So, histopathological diagnosis. Junctional component adjacent to the invasive tumor majority and expresses S100, HMB45, and Melan A. So this would be found in the biopsy. S100, HMB45, immunohistochemistry, S100, HMB45, Melan A. And perineural invasion is an important prognostic factor. Perineural invasion is important prognostic factor. Treatment. The overall prognosis of anal melanoma is dismal. 10 to 19 months survival after diagnosis. Only 10 to 19 months survival after diagnosis. Prognosis is very poor. Poor, and how much survival is there? 10 to 19 month survival after diagnosis. So melanoma does not respond well to chemotherapy or radiotherapy. It does not respond well to chemotherapy or radiotherapy. Thus surgery is the principal treatment when disease is localized. The extent of surgical resection is a matter of debate. Anal melanoma is very aggressive, and up to 35% of patients initially present with metastatic disease. 35% of patients initially present with metastatic disease. So it's a aggressive disease, aggressive cancer. 35% present with metastasis. And does not respond well to chemotherapy or radiotherapy. Does not respond well to chemotherapy or radiotherapy. Surgery is the principal treatment if localized. So surgery is the principal treatment if localized. Tumor more than 1 centimeter are unlikely to be cured by any type of treatment. Some authors claim that APR is the first choice of treatment, particularly for patients with small tumors and no evidence of nodal metastasis. However, as most patients with anal melanoma die of distant metastasis, major operative intervention like APR may not offer a survival advantage. Most patients with anal melanoma die of distant metastasis, so any major operative intervention like APR, abdominal perineal resection, may not offer a survival advantage, and some authors prefer local excision as initial treatment for melanoma. Melanoma of anal canal is sometimes detected as an incidental tumor when local excision is done for hemorrhoids. Okay, so melanoma, this is important actually. We can send hemorrhoidal tissue for HP as an incidental tumor when local excision is done for hemorrhoids. If R0 resection is achieved during local excision for hemorrhoids, patients do not need further intervention and have shown acceptable cure rates. So if R0 resection is achieved during local excision for hemorrhoids, patients do not need further intervention and have shown acceptable cure rates. Palliative local excision should be considered for patients with local symptoms due to anal melanoma. So, surgery is the only option if it is localized. So, anal melanoma is complete. Then